Okay. Hello, my name is Khistariya. I'm a final year medical student at GMERS Medical College, Sola. And today I'll try my level best to teach you a very important topic in pediatrics, that is severe acute malnutrition. Now, it is not a difficult topic to understand, but understanding it is actually extremely important for your clinical setting, because it is one of the most common presentations and cases that you will encounter, and one of the life-threatening conditions that you do have to have quite a good knowledge to be able to deal with it in the best possible way. Not only that, but as you move out as a doctor into the society, people will continue to ask for advice. So you do have to have complete clinical knowledge regarding this matter, because it has such a high prevalence within our country. So why is this topic so important? Well, in India, there is more than 8 million children with severe acute malnutrition. Out of the whole world, 31% of the children are from India that suffer from this severely wasted condition. And these children are at very high risk of death. That is why it is extremely important that we take this topic seriously. A general concept that was told to us by one of our pediatric consultants was that whenever you are learning a topic, imagine you are in the hospital. Imagine you are seeing the case in reality, because it will add that sense of realism to the topic, the importance to the topic. All right? Okay, let's continue. And it's quite a short topic, and I tried to make it as easy to understand as possible. So let's hope you guys benefit from this video. So when would we classify something as severe acute malnutrition? So let's just look at the first portion, severe. According to WHO, any malnutrition is considered severe when the parameters are changed by more than 3 standard deviations. And as we all know, any malnutrition that is acute will only affect the weight and not the height. So weight for height parameter will be greatly decreased in these cases. In terms of diagnosis, we look at 3 things. Any one finding from any of these 3 will be enough to make a diagnosis of severe acute malnutrition. Either the upper mid-arm circumference that is taken at the midpoint of your acromion process and your olecranon process. You measure the length, take the midpoint, and at that point you measure the circumference of the arm. If it is less than 11.5 centimeters, it classifies as severe acute malnutrition. Other than that, bilateral pedal edema. Now, it is important to remember here that this is actually a diagnosis of exclusion when it comes to bilateral pedal edema. Because as we all know, there are many conditions, renal conditions, liver conditions that cause pedal edema. So we have to rule out all other conditions before considering it to be due to malnutrition. However, if present and if you have ruled out other things, we can classify or diagnose the patient as severe acute malnutrition. And lastly, as I have discussed before, is weight for height being less than 3 standard deviations. Right. Now, how do we manage these patients? Right. Whenever they come in, we have to perform 3 tests, we have to see 3 things to decide whether they need to be managed in a hospital setting or at home. However, it is actually quite important to keep in mind that in our clinics, it was told to us, and in our hospital in GMERS Sola, that we actually admit all the patients, whether they are complicated or not complicated. Minimum 2 weeks admission is there for all severe acute malnutrition cases. So just so you know, even if it's not complicated, the mother will have no idea how to take care of the baby, and it might not be sufficient for us to just advise her once. She needs to see things for herself. Once she sees how people are managing the baby, what they're being fed, how they're making it, it becomes extremely easy and a lot more reliable to allow the mother to take care of the baby herself at home, right? So what are these tests? Okay, let's go through them one by one. The first test that is done is appetite test. Here what the nurse or the clinical person in charge will do is they will introduce some sort of feed to the infant or the baby, right? Now, if the baby accepts it, means he is hungry, he is ready to feed, it is actually a good sign, right? However, if he does not accept it, he is refusing to feed, that means his appetite has decreased, and that is a cause for worry. Then second finding is grade 3 edema, also known as anasarca. What is this? So basically we classify edema into 3 types: grade 1, grade 2 and grade 3. In grade 1 it is just feet edema. In grade 2 it is feet edema plus upper limb and lower limb are both edematous as well. And grade 3 is basically a generalized edema all over the body. And it is quite a bad sign, and such a person needs to be managed in the hospital itself. Or if the person presents with any of the following complications. Now a good way to remember this, I learned this in Maro, a good way to remember is by SHIELD. Right? SHIELD is the mnemonic that helps you remember the complications that are there. Firstly, S for sugar. We are looking for hypoglycemia. How will it present? Well, hypoglycemia generally presents as a seizure, like yes. So hypoglycemia and hypocalcemia, these two are the metabolic causes of seizure in an infant. So if an infant is having hypoglycemia, there is a great chance that he may come in with a hypoglycemic case. You see, whenever a patient comes in, it won't necessarily be for a severe acute malnutrition, but it is a secondary thing that you do take care of. So any infant you suspect having seizure, the first thing you're going to do is their glucose levels, their calcium levels, to rule out the metabolic cause. And next we look at hypothermia. If the child is hypothermic, that is, I'll be discussing these complications in detail one by one in the coming slides. However, it's good to give you a brief overview beforehand. So in terms of hypothermia, we know that the temperature of the infant should be maintained between 35.5 to 36.5 degrees. If it goes below that, it means that the children is suffering from hypothermia. And we have to manage them immediately. And then thirdly, it's infection. You see, a child that is suffering from severe acute malnutrition has very low immunity. And it's very likely that they'll be having multiple infections. In such a scenario, you do have to go for blood culture and all the necessary findings, and you cannot rule anything out. And generally, we tend to give empirical antibiotics to all the patients that are admitted in our wards. Other thing is to look for electrolyte imbalance and deficiency of micronutrients. Now, out of all of these complications, the most severe or the main causes for the increased mortality in this condition is hypoglycemia, hypothermia and infection, which generally are there or occurring as a triad. Okay, so let's look at things. Now, as we have described, hospital-based management and home-based, clinically in our hospital, 2 weeks definitive admission is there for all cases. no matter whether they are complicated or not complicated, right? So, but theoretically, this is what is advised, right? So let's move on. So home-based management. What do you have to advise to the mother or the relatives? What things do you have to keep in mind? It is extremely important that you get your message through. The communication has to be great, and you will also need the help of people that are visiting their home, the ASHA workers or other health workers that are going to guide them. So you need to train these workers as well so that they can advise accordingly. So what are the things? Let's go through them one by one. Firstly, nutrition therapy. What do we feed? We use something that is known as ready to use therapeutic food, RUTF. As you can see on the table on the right, this tells you about the composition of this material. It comprises of a peanut paste, sugar, milk solids, vegetables, and additional minerals and emulsifiers, antioxidants, vitamins, and overall comprises of 543 kilocalories per 100 grams. Now, what is so good about this kind of feed? Well, it tastes extremely good. Children do not understand that it's for their good, so you have to make them like it in order to increase the compliance of the child, right? So, yeah, so it actually tastes very good. Not only that, we know that in a child, he is suffering from a lot of things like diarrhea and malnutrition. His digestive capabilities are very low. So another good thing about this ready to use therapeutic food is that it is very easily digestible. So, good taste, easily digestible, easy to make at home. So it's a win-win situation in all cases. But at home, you do tell them that even though you are giving them this food, whenever the child asks for breastfeeding, you give them breastfeeding, right? Whenever a child seems to be hungry, because breastfeeding is the best possible food that exists, right? So in an infant, you always advise never to stop breastfeeding. Keep feeding them as much as they require and as many times as possible during the day. So how much are we supposed to feed in terms of calories? Well, as it clearly says, 175 kilocalories per kg per day, generally around 6 to 8 times per day. But you do have to advise them to be careful about a few things. As I said, these people or these patients are extremely immunodeficient. So you have to make sure that the surrounding area is completely hygienic. You have to make sure you wash your hands regularly because they may even get infected from normal pathogens that are opportunistic infections, as you call them, Right. Now, as I said, all children that are suffering from this because of the immunodeficiency, you give them or prescribe them oral amoxicillin as an empirical antibiotic for 5 days. Give a mega dose of vitamin A. That depends on the age. You see, less than 6 months old, you will give 500,000 units. 6 months to 12 months, 1 lakh units, and 1 year plus children will receive 2 lakh units, right? Apart from that, you want to avoid parasites. For that, you give a single dose, 400 milligram albendazole medicine. Assure that they have been vaccinated. If not, you give them all the required vaccines that are needed up till that point or whatever age it is. For example, if it's 9 months old, they should get all the vaccines from birth, that were required at birth, at 6 weeks, 10 weeks, 14 weeks, and then at 9 months, that is the vitamin A administration. Not only feeding and physical condition needs to be kept in mind, but these children have a tendency to go act lethargic, hypotonic, So we have to make sure that we are actually stimulating them to play, to interact, to perform physical activities, have fun. It is extremely important for the mental health of the baby, and it actually can make or break the situation. A good, healthy, happy baby is extremely important in these cases. Apart from that, you will need supervision and support from health workers. You see, we belong to a society where there's a lot of illiterateness. A lot of people take things very as if it's not that important. They don't take things seriously, or they do take things seriously but are not able to understand exactly what to do. So regular follow-up by these ASHA workers and health workers, or regular things keeping up, and they have to assess whether the child is growing, coming out, is he still experiencing anything new, are the practices performed by the mother correct, is she doing the right things, whatever she is not doing she should be advised to do from now on, etc. Right? So it does keep a good sense of feedback. Right? Okay. So now we discussed that what children needs to be admitted to the hospital. Now the management of these infants or children is actually divided into two phases. One is the stabilization phase that lasts for about 1 week, and then there is the rehabilitation phase that will last for about 4 weeks after that, 4 to 5 weeks after that. Right? So what do we take care of in the stabilization phase? In the stabilization phase, our primary goal is to control all of the complications that were occurring in that patient and stabilize the patient, make him able to actually increase his diet, make him able to get the situation under control. So ideally, the first three conditions, hypoglycemia, hypothermia, dehydration, we need to manage these within the first 3 days, when we need to get these under control because of the high rate of mortality associated with them. Now, initially, yes, as it says, one of the things that one of my colleagues actually asked during their clinics was, why don't we give them IV nutrition? Any case of shock, any case of weakness in a hospital setting, whenever an adult is there, the first thing they do is give them IV. So why not here? What is the issue with that? Well, you see, severe acute malnutrition is a very peculiar condition. What happens is, these people have undergone malnutrition in a very short period of time. So the organs and all are very sensitized and are very prone to getting decompensated at any time. So whenever we give IV nutrition, there's a very high chance that we may precipitate cardiac failure, or many other organs may be decompensated. So we have to be very careful. The only indication of IV nutrition is if a person is having symptomatic hypoglycemia. In that case, we have to go for IV dextrose. Otherwise, we try and avoid it in all conditions. Right? Now, another thing that we have to keep in mind is the F75 and F100 feeds. That is formula 75 and formula 100 feed. Formula of 75 is basically 75 kilocalories and 0.9 milligram per 100 grams of feed. And F100 feed contains 100 kilocalories and 2.9 milligram per 100 gram of feed. Now, why are these two separate entities there? Well, there is something known as refeeding syndrome, which will come up later in the slides, and I'll discuss it in detail there only. But talking about it briefly, in a child that has just undergone extreme malnutrition, who is on edge, who has had severe diarrhea. The epithelium of the gut is not proper. So his digestive capabilities will also be extremely less. He won't be able to handle a sudden rise in food. So we have to be very careful in these patients that we slowly introduce food and slowly go on increasing the quantity. Otherwise, what may happen is there is a syndrome known as refeeding syndrome, where a sudden increase of food will induce a large amount of insulin secretion. And one of the functions of insulin is that it moves the ions from the extracellular compartment to the intracellular compartment. This will lead to a hypomagnesemia, hypokalemia, and this will ultimately cause an increase in the edematous condition. So we have to be very careful that we start off slow, we start off small, and then slowly go on to increase the calories of the children.